All right, let's dive right into a really critical topic, acute heart failure. This is a true medical emergency, and today we're going to break it all down. We'll follow a patient's journey from the moment that crisis hits all the way to their long-term game plan.
So just imagine this for a second. You feel like you can't get enough air, like you're drowning, but you're not even in water. You're just lying still. It's a terrifying feeling, and it's the reality for someone in acute heart failure. So, what on earth is going on inside the body to make this happen?
Well, acute heart failure, or AHF, can show up in a couple of ways. It could be a brand new, out of the blue diagnosis. Or if someone already has chronic heart failure, it's a sudden, dramatic nosedive in their symptoms. We call that a decompensation. But either way, the bottom line is the same. This is a full-blown crisis that needs urgent, immediate medical care.
Okay, to really get this, let's use a simple analogy. Think of your heart as this amazing high-tech pump, and your blood vessels? That's the plumbing. In heart failure, that pump just isn't working right. It can't push blood forward like it's supposed to. And what happens when a pump fails? You get a backup. The pressure builds, and fluid starts to back up into the lungs, the legs, everywhere. That backup, that fluid overload, that's what we call congestion.
Now, a failing pump isn't just one thing. It can fail in two main ways. On one hand, you have what's called HFrEF, or heart failure with reduced ejection fraction. This is the weak pump. The heart muscle itself is too weak to squeeze properly. On the other hand, you have HFpEF, heart failure with preserved ejection fraction. This is the stiff pump. The muscle is strong, but it's too stiff to relax and fill up with blood in the first place. The key number we use to tell them apart is the LVEF, which basically measures how much blood the heart pumps out with every single beat. All right, so let's get back to our patient. They've just arrived in the emergency room. What are the first symptoms, the first clues that make a doctor think, this could be acute heart failure?
You know, all these classic symptoms really point back to that plumbing backup idea. You've got dyspnea, just general shortness of breath, but then there's orthopnea. This is more specific. It's when you can't breathe lying flat, so people end up sleeping propped up on a bunch of pillows. And then there's PND, or paroxysmal nocturnal dyspnea. This is that horrifying moment when you wake up in the middle of the night, literally gasping for air. These are all huge red flags for fluid overload.
So the doctor starts their exam. What are they looking and listening for? Well, they'll check the neck for jugular venous distension, or JVD, where the veins are bulging from all that back pressure. They'll listen to the lungs for crackles, which is literally the sound of air bubbling through fluid. And with their stethoscope on the heart, they might hear an extra sound, an S3 gallop, which is the sound of a very stressed, overfilled heart.
And here's something you can see with your own eyes: pitting edema. Remember our plumbing backup? The pressure in the system gets so high that fluid actually leaks out of the blood vessels and into the skin. So when you press down on it, your finger leaves a little pit, an indentation, because you've just pushed that extra fluid aside. It's a direct visual sign of that congestion we've been talking about.
Now, here's a really important point. This kind of crisis almost never happens out of the blue. There's usually a trigger. So a big part of the job in the ER is to play detective. What pushed this person over the edge? Did they eat a super salty meal? Did they forget to take their water pill? Or is it something more serious, like a brand new arrhythmia or even a heart attack? Finding that trigger is key.
Okay, so all the signs are pointing towards acute heart failure. The story fits, the exam fits, but suspicion isn't enough. You need proof. So, how do we confirm it? Let's get into the diagnostic toolkit.
First up, blood tests. And the absolute star of the show here is a test called BNP, or NT-proBNP. Think of it as a scream for help from the heart. When the heart muscle is stretched and strained by all that extra fluid and pressure, it releases this hormone. If the level is sky high, it's a very, very strong sign that you're dealing with heart failure. Of course, we're also checking things like kidney function, electrolytes, and cardiac enzymes to make sure a heart attack isn't the culprit.
Next, it's time to get a picture. A simple chest x-ray gives us our first visual proof of all that congestion. We're looking for things like pulmonary edema. That's fluid inside the lungs, making them look all white and fluffy instead of clear and dark. We might see an enlarged heart, what we call cardiomegaly, or even fluid around the lungs, known as pleural effusions.
And here you can see a perfect example. Look at that heart in the middle. It's huge. It takes up way more space than it should. And then look out at the lungs. See all that hazy white stuff? That's not supposed to be there. That's fluid. This is the picture of a heart and lungs that are just completely overwhelmed.
But the real gold standard, the test that clinches the diagnosis, is the echocardiogram. This is basically an ultrasound of the heart. It gives us a live, moving picture of the heart muscle as it works. This is how we can measure that critical LVEF number and figure out if we're dealing with a weak pump or a stiff pump. We can also check out the valves and look for any other structural problems. It's the definitive test.
So, the diagnosis is confirmed. Now the clock is really ticking. The focus shifts instantly to stabilizing the patient. This is a true emergency, and what we do in this first hour can make all the difference. The initial steps are all about logic and priorities. First things first, if they're not getting enough oxygen, you give them oxygen. Makes sense, right? Step 2, and this is the big one, you hit them with powerful IV diuretics. The goal here is simple. Get that extra fluid off and get it off fast. If their blood pressure is high, we can also use vasodilators, like nitroglycerin, to help open up the blood vessels. This takes a huge amount of strain off that struggling heart pump.
Getting that diuretic dose rate is so important. A lot of these patients are already taking a water pill at home, but that's not going to cut it in a crisis. We need the stronger, faster IV version. And that means you have to know how to convert their home dose to an equivalent IV dose. For instance, 40 milligrams of oral furosemide is about the same as 1 milligram of IV bumetanide. Knowing these conversions is absolutely crucial for treating the patient safely and effectively. And as we're aggressively pulling all this fluid off, we have to watch the patient like a hawk. It's a delicate balancing act. We measure every drop of fluid that goes in and every drop that comes out. We weigh them every single day because their weight is the best measure of how much fluid they're losing. And we're constantly checking their blood pressure, their kidney function, and their electrolytes, especially potassium, which can get dangerously low with these strong diuretics. Okay, so we've pulled the patient back from the brink. The acute crisis is stabilizing. That's a huge win, but it is just the beginning. The focus has to pivot now, from the emergency to the long game. How do we keep this from happening again? This one number really tells you everything you need to know about how serious this is. After a single hospitalization for acute heart failure, the 1-year mortality rate is between 25 and 30%. Let that sink in. This isn't just a bump in the road. It's a major event that signals the disease has gotten much, much worse. It's why aggressive long-term treatment is absolutely non-negotiable. The good news is, for HFrEF, that weak pump type, we have an incredible arsenal. We call them the 4 pillars of therapy. These 4 different classes of medications have been proven over and over in huge studies to keep people out of the hospital and, most importantly, help them live longer. The goal for every single one of these patients is to get them on all 4 of these life-saving pillars if possible.
Now, this is something that trips a lot of people up, so let's clear it up. There are 2 ways we classify heart failure. The AHA-AC staging system, that's stages A through D, is about the disease itself. It tracks how the heart has structurally changed over time. If you're stage C, you're always stage C. But the NYHA class, that's I through IV, is all about symptoms. It describes how you feel day to day. So you could be a stage C patient who feels great one day, that's our NYHA class I, and be in crisis the next, NYHA class IV. One tracks the disease, the other tracks your daily life.
And this right here, this quote from the official guidelines, really sums up the whole modern approach to care. The old way was just to get the patient stable and send them home. Not anymore. The standard of care now is to use that hospital stay as a golden opportunity to get patients started on those 4-pillar medications and to push the doses up as quickly and safely as we can before they leave. We know that doing this dramatically cuts their risk of coming right back to the hospital, and it helps them live longer. So, we've walked through the entire journey, from the moment of crisis, through the diagnosis and emergency treatment, and into the plan for long-term care. The science has given us some truly amazing tools, but it leaves us with one final big question. How do we best empower our patients to become the experts of their own condition, to become true partners in managing this long after they've left the hospital? Figuring that out, that might just be the next great frontier in heart failure care.